Okay, so let's take a look at some pain rating scales or pain patient-reported outcome measures. So if we just look at pain, you could have a simple rating scale. And I know many chiropractic patients come and see us because they're in pain. So it's a good thing to monitor pain if someone has come in to see you and they're complaining about pain. We also know that chiropractors are very good at helping people feel less pain. So again, this is a good thing to measure to show that you are helping them get better. You'd be surprised at how quickly people forget what they originally came in and complained about. So it's very, very good to note it down. Again, I'd like to encourage you to check out the many classes I've got in the Basic Science for Chiropractors courses, because there's a lot of new information now about how we understand what pain is and how involved the brain is in the experience of pain feelings. I've also got several classes in the Clinical Science for Chiropractors course about pain and how good chiropractic is to help people experience less pain, so reducing pain. Now, what I've got on the slide here is a simple pain rating scale. It's a 10 centimeter long line, and one end of the line represents no pain at all, and the opposite end represents worst imaginable pain. So this is known as a visual analog scale, or a VAS, visual analog scale. The patient would mark off on this scale how intense they feel their pain currently is, and you can then measure it because each millimeter is obviously 1, or you could do it out of 100. But each millimeter, you can literally then measure the line. There are no markings on the line in a visual analog scale. So this simple line with no markings, then it's called a visual analog scale. But you can also mark it, and you can number it. And in this instance, it's referred to as a numeric rating scale, because you've got numbers here now, where the patients would choose one or more of these options. So you can ask them to rate their pain with a number. Then it's a numeric rating scale. They can even use half numbers, so they can say it's 4.5. My pain is currently 4.5 out of 10. So that's also possible. Usually on the numeric rating scale, up to 3 is considered mild, between 4 and 6 is considered moderate level pain, and 7 and above is considered severe pain. On all 3 of these levels that we've just discussed about PROMs, that you can think about patient-reported outcome measures, it's good to know how much pain a patient is in before and after a period of care. Whether you're just talking about the clinical encounter, it's great to remind patients about how bad they were when they started to see you and to compare this with where they are at now. It also helps to show them the value of your care. Despite this being just one aspect, and it is only just one aspect, pain feelings is just one outcome of chiropractic care, it's still a great one. I mean, I don't know about you, but it's not fun to be in pain. And I have experienced years and years of pain, so getting out of pain is a good thing. I know it's just one aspect, but it's an important aspect. But rating pain and pain improvements isn't just important for the clinical encounter level, it's also important at the multi-practice or the professional benchmarking level. It's good to know how thousands and thousands of patients respond to chiropractic care, even from just this simple pain rating scale level. Knowing what's normal for patients. How many centimeters do pain levels usually drop in the numeric rating scale or the visual analog scale after a period of chiropractic care? Again, you can use this to benchmark yourself. How good does the profession achieve, but how good do you achieve compared to the profession within your patients? But this kind of data is also extremely useful for the policy and decision-making level. Knowing that chiropractic can improve pain feelings as good as any other intervention out there, and with relatively no side effects, no real dangers, there's no real massive dangers with chiropractic care, such as can occur with opioids or surgery, for example, then chiropractic care becomes a fantastic option for people that are in pain to try first. And that's, again, where PROMs can make a big difference. And if you think about it, chiropractic care is also, relatively speaking, very cheap, again, compared to surgery or compared to opioids when you take into account the cost to society for having to deal with the opioid epidemic with people that are addicted to heroin because of opioid drugs. So if you've got this kind of data, that patient-reported outcome measures is also a very important part of the decision-making process of policymakers. They can see then from lots of different reasons that chiropractic care is a superb option and choice for people with pain. And that is literally what's happening around the world today. Policymakers are pushing chiropractic care as one of the best conservative options that there is that's out there to try for low back pain, neck pain, and headache patients. And this isn't obviously only due to patient-reported outcome measures, but it plays a part. And that's why we need to make sure we don't forget about them. The good thing is that this is well used by chiropractors in general. We know from research studies that have been done that the four most commonly used patient-reported outcome measures for low back pain patients in the chiropractic literature is the numeric rating scale, the visual analog scale, these two we've just talked about, and also the Rowland-Morris questionnaire and the Oswestry Disability Index. So let's take a look at them. So the Rowland-Morris Disability Questionnaire, it can be used both in research and in clinical settings. So the original questionnaire was all translated, it's all on the public domain, so you don't need any permissions to use this, and it's been translated into over 50 languages. So it's very well documented. The original version of the Rowland-Morris Disability Questionnaire, which is the one I'm showing you here on this slide, was first published by Rowland and Morris in 1983, hence the Rowland-Morris Disability Questionnaire. A review of the paper and the questionnaire was published in 2000, and you've got both of these references in your key reference slide. So the Rowland-Morris Disability Questionnaire is scored by adding up the numbers of items checked by the patients. So the score can therefore vary from 0 to 24. Now, it's not recommended to give patients an answer yes or no. Instead, you ask them to tick those that apply to them, and then you score it out of a maximum of 24. So a substantial number of papers have been published on the psychometric properties of the Rowland-Morris Disability Questionnaire. And the psychometric properties means that they test the validity and the reliability of it. That's what psychometric properties mean. So many studies have shown that the Rowland-Morris Disability Questionnaire has got excellent validity and reliability. And remember how important it is. Any patient-reported outcome measure you choose, you've got to make sure that it has got excellent psychometric properties in your language. If it's not English, make sure that it has been validated and is reliable in different languages. So on the slide here too, I've got the instructions that you would normally give your patients, and then you literally ask them to tick or circle each of these different statements that suits their pain experience. You know, for example, I stay at home most of the time because of my back, or I change my position frequently to try to get my back comfortable, or I walk more slowly than I used to because of my back pain. So that's the kinds of things that they would tick. You can read the rest yourself. So here's the Oswestry Disability Index. Again, here are the instructions that would be given to your patient, and then for each of these different subsections, these 10 subsections, they would tick one of the boxes. For this Oswestry Disability Index, it gives a subjective percentage score of level of function, or therefore also level of disability, in activities of daily living in those who are attempting to rehabilitate from low back pain. So the Oswestry Disability Index, just like the Rowland-Morris Disability Questionnaire, is also reliable and valid. And it's a very suitable measure for disability in patients with low back pain. Now, studies have compared both of these two different questionnaires, and they usually come out head to head. So they're usually kind of as good as each other, except what seems to be the most accepted recommendation is that for persistent severe disability patients, then you use the Oswestry Disability Index, while the Rowland-Morris is better for mild to moderate disability. So if you've got very severe patients, then I would use this Oswestry Disability Index. If you've got more mild to moderate disability from low back pain, you're better off using the Rowland-Morris. So that's how you would choose between the two of them. Now, taking a closer look at this Oswestry Disability Index, it examines the perceived level of disability in these 10 different everyday activities of daily living. So it looks at pain intensity, personal care, lifting, walking, sitting, standing, sleeping, sex life, if applicable, social life, and traveling. And then under each of them, you can score one out of these 5 statements. So from 0 to 5. So it's really scored out of 6. So 0 is that there's nothing at the moment, not affecting you at all, whereas 5 is worst possible imaginable at the moment. So each of these scores, you add them up, and this gives you your overall index, or the Oswestry Disability score or percentage. So you work out this percentage, and that's how it's interpreted. So once you have your percentage, you can then interpret where you're at if you have minimal, moderate, or severe or crippling disability. So from 0 to 20, you have minimal disability. From 21 to 40, you have moderate disability. From 41 to 60, you have severe disability. From 61 to 80, it's crippling. And from 81 to 100, these patients are literally bedbound, and it's horrific. So hopefully you won't be seeing many of them. Hopefully many of them don't exist. They've also got this neck disability index. So this is one that's specifically for neck pain now, not for low back pain. It was developed by Howard Vernon and Sil Muir, both chiropractors and PhDs. And this has been like a modification of the Oswestry Low Back Pain Disability Index. So the Neck Disability Index is a patient-reported outcome measure that is specifically for neck pain disability. And again, testing their functional status with 10 questions about their neck pain, pretty much exactly the same as the Oswestry Disability Index, but for neck pain. And again, it's been translated into many, many different languages, and it's got excellent reliability and validity. So here you can just see those 10 different sections again for the neck pain disability. It's their pain intensity, personal care, lifting, reading, headaches, concentration, work, driving, sleeping, and recreation. Now, the Bournemouth questionnaire is a comprehensive, multi-dimensional core outcome tool assessing patient outcomes in routine clinical setting. So interestingly, again, this one was developed by Jennifer Bolton, PhD, and Alan Breen. So there's, again, two versions of this. There's the low back pain one and the non-specific neck pain one. And both are considered reliable and valid. So these are a bit all-encompassing in a way, both the pain intensity as well as disability. So they're asking on several different numeric rating scales here from 0 to 10, with over the last week on average, how would you rate your neck pain or back pain, depending on which one you're using. And over the last week, how much would your neck pain interfere with your daily activities of living? And again, over the past week, how much does your neck pain interfere with your ability to take part in recreational, social, or family activities? How anxious are you over the last week? And how depressed are you? So it's taking into account the mental health, physical ability, as well as pain ratings. And how have you felt that your work is affected by your pain? And over the last week, how much have you been able to control your pain on your own? So it's taking into account mental health as well as the pain levels and how much it's interfering with disability. So it's a little bit more comprehensive than just looking at pain, which like the visual analog scale or the numeric rating scale, or just looking at the disability aspect of pain. I want to talk a little bit more now about the psychosocial aspects of pain and how you can also take them into account. But before we do that, just pause again and test yourself to make sure you're picking up on the key concepts.